In addition to serving on SoCal HIMSS, I'm also the Chief Medical Officer for an AI startup company called Giant, and I also serve on the steering committee for Scale LA, which you've heard mentioned a few times today, the co-working healthcare incubation space located here in West Los Angeles. But my role today is really to facilitate a discussion with this esteemed group of speakers who I've had the pleasure of getting to know over the past several months. So without further ado, I'm going to let them introduce themselves and their background. The words on the screen do not speak enough about their experience, but they definitely will share perspectives on the challenges of using technology to combat and tackle and deal with the problem of chronic disease, which is using up a lot of our current healthcare resources. So I'll start with Midori.
Thank you for having me. I'm Midori Kondo. I'm a PharmD. I did my residency and fellowship at University of Washington, and I have a master's of health administration, really promoting the pharmacist role and chronic disease has been a passion of mine. I've been on the operational side and moved over into the technical side just because I was interested in developing products that could actually help us in our clinical care and helping our patients. Thank you.
Hi, my name is Anil Goud. I'm the Director for Clinical Informatics and Analytics at Cedars-Sinai Health System. Background is as a hospitalist as well as a primary care and palliative care medicine, and now focused mainly on data analytics as well as informatics, both on the inpatient and outpatient side, and population health at Cedars.
Great. Hi, Piyush Gupta. I'm an internist. I'm a practicing physician at CareMore. I'm also the medical officer for CareMore Arizona. So I work at the same organization as Omid. We're a payer provider for both Medicare and Medicaid wraparound delivery system all across the country.
I think I'll just use yours. I'm Stan Frencher. I'm the Chief Medical Officer at Wise Healthcare. I'm a urologist by training. I did my undergrad in Michigan at medical school at Albert Einstein College of Medicine, where I also got my MPH in Health Policy and Administration at Columbia. I was at Arbor Wood Johnson Clinical Scholar at UCLA, where I'm currently an assistant professor in the Department of Urology. At Wise, we do a lot of work focused around artificial intelligence and also workflow innovation, science, and engineering, which is what Wise stands for, largely trying to impact the safety net by improving access to care. My passion as someone who's a native of Detroit is focused around health disparities and improving access to care in any way that we can.
So we'll start with Stan, and my first question for the panel is to share a little bit more about the projects, initiatives, other things that you're working on in your organization or plan to do in the near future around these topics, right? You mentioned social determinants of care, also health IT or technology, and then also the theme of today's panel, chronic disease. So focusing on the patients that have a lifetime of medical challenges ahead of them, how do we really leverage these resources and the scarce resources we have, and what is your organization doing about that?
I think my first introduction to telehealth was really focused around the work that I do for LA County DHS. So there I'm the lead urologist at MLK Outpatient Center, and I became the co-chair of their e-consult work group. So e-consults, for those who aren't aware, are provider-to-provider communications between primary care and specialists. Oftentimes, accessing care for Medicaid patients or those in rural areas is difficult, as we've all been talking about. But one of the potential solutions is to expand our ability as individual practitioners by allowing us to supplement the care that's provided by our primary care colleagues. My father's a primary care doc growing up, and so clearly, like, referring patients to specialists that don't exist is really challenging. And so for those who are taking care of Medi-Cal patients, being able to reach out to a specialist through an electronic dialogue that also is then augmenting their electronic medical record when they do come and see us as a specialist has proven to be a really great modality. If you look at the data, recently in Health Affairs, Paul Gibbity and their group at LA County DHS demonstrated that you can reduce the number of needed specialty appointments by at least 30% by using this approach. And so when you start to think about patients who have chronic disease like diabetes and others, you can't hire enough endocrinologists to provide all of that care. And oftentimes, with just the simple help of a specialist by aiding them and adjusting medications through an e-consult dialogue and then deciding the urgency with which that patient needs to be seen, one can improve their access. And so part of our work has been implementing that tool in the Inland Empire for Inland Empire Health Plan and their 1.2 million members across their primary care and specialty groups in that geographically vast area. And so in doing so, we've been able to help patients gain access to specialists by ensuring that their primary care doctors have access to them to answer those questions. I think that for the sake of this panel and this discussion, I think that using asynchronous communications between primary care physicians and specialists is a great tool, particularly if it also is augmented by other modalities like televideo and other means with which one could continue to expand. So you can imagine a scenario where now you're taking care of patients longitudinally over the course of a disease process by initially having their primary care doc engage with their specialist, ultimately being able to engage directly with that specialist between the patient and their specialist through a televideo, and then finally seeing them face to face. You start to eliminate the need for individual face-to-face visits and therefore expand access. So that's been kind of our strategy and focus of trying to do that for patients in the safety net.
Great. Piyush?
And so the question is specifically around social needs, is that correct?
No, just what your organization is doing around these topics: chronic disease management,
Sure.
the use of health IT, and obviously some consideration of the social determinants of health.
I think as every organization analyzes that question, I'm sure all of you have poised it or thought about it in some way. It actually, I think we all need to take a step back and say, what do our patients need and what are the clinical teams that we need to form them? And then what's the technology that we need to support that clinical team? So some of the things that we've done over the past year, one of the things I'm really proud of is our hospital at home model. So we are seeing, as we're breaking through a lot of the financial reimbursement models, how do we actually take care of our complex patients at home for an extended period of time? How do we avoid costly hospital admissions? How do we use RNs or LPNs with physician or NP oversight, whether it's through video or through virtual monitoring, to make sure that we're able to keep those patients at home? And so some of the cases that we've seen are basic admissions, whether it's cellulitis, COPD, pneumonias, UTIs, that otherwise would be an overnight 1 to 2 night stay at the hospital. Other things that I'm really proud of is a lot of our remote monitoring tools. And again, that's not unique. I'm sure if I surveyed the room, probably at least half of you would raise your hand and say, yeah, we have remote monitoring tools. But again, it's how you match it to your clinical organization, right? So is your clinical organization able to respond to someone who's having an increased weight Saturday morning on New Year's Day, right? So yes, we give out the clinical tools, the monitoring tools to patients to watch their weight and watch their blood pressure and watch their glucose. But if there's no clinical wraparound service to augment that, it doesn't really matter. The third thing I'd look at is kind of like, what I like to say is completing the swing. Right, so we refer a lot to our social workers for helping them with social needs, whether it's housing, food, at times education, or whatever else your demographics for your population needs. But a lot of physicians and a lot of organizations I've seen just kind of wash their hands after that one referral. Right, just, we referred to social worker, it's done. There's a case management on the team, and so all the needs are taken care of. When in actuality, it's all the support teams that need a lot of assistance and technology as well. It's not just the MD, it's not just the RN, it's not just the NP, it's not just the PA, it's not just the administrators that need all your data and reporting. So what I ask everyone in the room is continue to look at all the needs of your organization beyond what's typically focused on.
So yeah, Cedars-Sinai, it's a very matrix organization. We have a medical network, we have faculty, we have licensed clinic spaces, so a lot of different places. And from an IT perspective, how do you support all of those who have populations that overlap each other? It's kind of a Venn diagram of patients being taken care of in different settings. And then there's that subset of population that is on our ACO panel or at-risk panel that aren't in our system because they're just not showing up. right? So there are a lot of different pockets. When it comes to chronic disease management, part of the challenge is building an IT system and structuring it so that you can support all these different service areas, but also try to find out how you can engage the patients that aren't necessarily coming in at this time. For chronic disease, with regards to diabetes, hypertension especially, we use a lot of pharmacists, and I think Midori Kondo, who was previously at Cedars, may have probably set that up before my time. But it's been a great success to be able to leverage pharmacists to be able to take these patients and really be the captain of the ship when it comes to that condition. But how do you connect that patient back to the primary care provider and the specialist, make sure that everyone is seeing the same thing and understanding what's happening across the continuum of care? And we use tools like longitudinal plan of care within our EMR system to be able to do that. And also, how do we take in data from the HIEs that come in from external sources to be able to create surveillance for patients maybe we aren't seeing because they're not coming in, or because their appointment is set up but it's 6 months from now and something's coming up. How do we set up a surveillance across, and then how do we communicate that across the different systems? And the outreach for these patients also has to be coordinated so that you're not necessarily bombarding them with 5 different service lines, contacting patients, that one patient getting 5 different messages from 5 or 6 different folks. So, we're doing a lot of work around trying to coordinate all of that, at the same time doing practice transformation at the actual office and clinic level to make sure that the patients are getting the full experience, that all the dots are being connected for them when they do come in, so that they're not having to come in multiple times to have the different things addressed in the different areas. So there's a lot of work to be done, and I think we're on the path to doing it. We don't have all the solutions, but I think we're starting to put some of the pieces in place.
Midori?
So, as a pharmacist, I have to take my moment, because I actually think that pharmacists are not utilized to the top of their license and training. And one of the biggest things that I've seen working with multiple organizations, and I'm currently living in the Central Valley, and I still actually do health fairs and still keep up my clinical skills just to mentor our next level of workforce, to make sure that the pharmacy students have a place to actually do some health screenings and work with our population. But it's been kind of a wave for pharmacists, where in the 90s we really were pumped up a lot on using the pharmacist to counsel patients on their medications. I mean, that just was from the 90s. We've seen, SB 493 passed in the state of California to recognize pharmacists as providers. We have our PharmDs now. We go through a lot of training to be able to do some clinical assessment, and to be able to now, as a provider recognized by 493, we're able to do a lot more. Yet we see a lot of pharmacists not being used in the workforce to help our physicians and other team members to do these clinical assessments and providing recommendations to the physicians to partner with them to take care of these patients. I think, utilizing our workforce to, everybody, all the different types of roles in healthcare and the care team to the top of their license is the best thing that we can do to start to tackle this bigger issue of what do we do with chronic disease. So I agree with my colleagues here around having the team, picking the team, figuring out how to utilize the team, and then the tools in order to make that happen. There's been a lot published around, pharmacies are within 5 miles of most people's homes. So it's a good opportunity to partner with local community pharmacies, as well as your pharmacists within your healthcare organization, to help tackle this big issue.
That's a great point, and I think there's been a lot of news articles around putting the medical clinic into the convenient locations, either retail, shopping centers, CVS, Minute Clinics. All of these things are a way to leverage the accessibility for patients, because they're seeking different things now. I think the patients that aren't sick yet or getting sicker expect healthcare to be delivered in a different way than what we've seen traditionally. And so the challenge, I think, some of you can answer is, as we engage these groups of providers, physicians, pharmacists, nurses, who have been taking care of chronic disease for their entire career. They've been dealing with diabetes and hypertension and heart failure. And now we come at them with these tools and say, we're gonna make your job easier, you're gonna have better outcomes, costs will go down. What have been the resistance you've felt within your organizations, either in your current role or previously, and how have you managed to try to get them to align with what your goals are for delivery of technology and in essence, trying to improve chronic care management? So I'll open it up to anyone on the panel.
I'll go ahead and start. All right. So, I think one of the challenges with electronic medical records for physicians is you've kind of taken them out of their natural habitat and put them in front of something that's just not something they're used to using. And on top of that, you've put in a lot of policies and now data collection requirements that changes also their ability to fulfill all those needs to actually, quote, take care of the patient, even though all along they've been taking care of the patients when they've been seeing them. Technology, though, they do appreciate for the fact that it does help them remember things that maybe they wouldn't have thought about, and it brings up information that if they're going to order a certain medication, help them understand if there's a potential cross interaction, or if there's a care gap that they didn't realize the patient had done to be able to do that. But I think one of the things that we did when we implemented EMRs is we told them, here's how you use this tool, but we didn't necessarily look at their practice and understand that actually needs to change and how they actually need to transform everything from how they contact patients, how they bring in patients, what they do when they actually see the patients, and what the post-visit, the outreach process, all of that is. And that's something we're now just starting to piece together and build together for these clinicians. The amount of data that's coming in for these clinicians is tremendous. There's data coming in from HIE, there's data coming in from places that they didn't even know patients were collecting data. In the past, patients sat in front of you and you spoke with them and they told you everything, and it was concise, and for the most patients, not all, but for the most part concise, and they were able to kind of give you the history and everything there. But now you have all this data coming in, you kind of have to put the story together. You kind of have to reconcile all of that information. And that's a bit of a challenge, especially in a clinical system that doesn't necessarily allow you to do that automatically. And not sure you necessarily want an EMR to do everything automatically either. If you had a colonoscopy done somewhere, you had a pap smear done somewhere, great, you could satisfy my care gap, but what if it was abnormal? How are we going to make sure that the frequency of the potential surveillance for this patient now changes, or things like that? So I think there's a lot of nuance with regards to using technology, but you can only go so far until additional technology is available to make that even easier. So maybe AI, natural language processing, can start looking at the pathology reports and all this stuff, and then actually integrating, again, back with our way that we manage care gaps in the system. So we have to kind of take it a step at a time, without overstepping and saying, great, we have all this data, we're going to just throw it in your system for you, and we're going to satisfy all this stuff, but you're going to be blind to understand what's actually happening with your patient and things that you should be concerned about. Now it seems like you don't need to be concerned about. So I think there's a risk with all of that, and physicians, especially physicians that understand that this is an issue, are the ones that come back and say, this doesn't work for me as well because I'm losing this. And you have to be a little bit scared about the physicians that are just kind of taking it all in and seem super happy, because maybe they're not realizing some of these nuances with this information that's sitting out there that they need to be concerned about.
Please.
I was just going to make a comment. I loved in the interoperability session, they were talking about how the focus has been more on adoption instead of care coordination, and I think that that's actually a really true statement. I mean, if you even look at EMRs and, when you start to bring up chronic disease management and everything that needs to be coordinated with the patient, the standard kind of module doesn't work that way on tracking all of these patients and have they come in, when need to come in next, what's happening to them until they end up having some sort of complication or progression of disease, and then now we're reactive in trying to manage that progression of disease. I'm thrilled to think of the possibilities around AI, because even with all these other modules that are out there, it's still, we end up with challenges on security access to be able to see what somebody else sees. And with AI, I'm really excited to see if all of this can actually come together and present something in a way that is really actionable for people to be able to track these populations, because the populations just keep growing and more complications we end up being very reactive and kind of behind the 8 ball.
Yeah, I think my passion for telehealth actually was born out of this question, right? Because I'm not really like hugely about the technology. Like I clearly, from the work that we've done, recognize that it's about workflow and it's about understanding the work that the providers are doing and engaging with the technology. So sentinel to any of the work that we do, it's always about engagement first, like trying to understand first and foremost what problem are we trying to solve with the technology we're implementing, and then ultimately, like how is it going to disrupt the workflow of the folks we're working with? Because quite frankly, their adoption, their care coordination, their use of the modalities is completely going to hinge on, like, did you really engage with them from the beginning? Do you understand what their workflow is before you kind of plop this new technology in front of them? And frankly speaking, getting that stakeholder buy-in is key particularly for providers. And so that's 100% of the work that I do in terms of talking with the docs, trying to understand their workflows, trying to work through the issues that arise in integrating technology into their workflow, and trying to understand how it's going to either enhance or make it worse. I think without that kind of level of engagement, most of these technologies end up being underutilized. Like things like using these telemedicine robots and that become coat hangers in our hospitals. Like and it's just the nature of how technology is if you aren't really engaged with the end user from the beginning.
I think to piggyback on what Stan said here, I think organizations, previous organizations that I've worked at, not been as rigorous when we're evaluating technologies. What I mean by that is, just like what Stan was saying and just like what everyone else has been saying is analyzing workflows, it's also been, just get a little more detailed. Do a randomized controlled trial. Well, how much time does it take to complete task X? Right? Did this new technology actually increase the time or decrease the time? And if it didn't decrease the time, we should just stop, move on, go do something else. But be a little more rigorous, and the solutions don't come up from the C-suite or the VP level. It really does come from frontline staff.
And to ask a follow-up question, what has been kind of the biggest pushback when you try to implement something new, especially in your roles, engaging clinicians or even executives to say, hey, we have something that could meet some performance metric or drive some efficiency or improve patient experience? What has been the biggest argument back that you guys have to constantly battle against in order to get engagement or adoption?
Don't give me more stuff. Right? I don't even want to know how many applications that a physician or an NP or an RN has to log into in your system. I've heard at times upwards of 20 applications that someone has to log into to just check in a patient. I mean, it's insane. Just don't give me more stuff. Give me one platform that's got everything, that's ideal state, and if not, maybe 3. But I mean, 16? Can you imagine practicing medicine in the future if we're at 16 right now and what we were at 10 years ago?
Yeah, from our standpoint, interestingly, a lot of times when we're starting to use new modalities, we're changing the way we practice medicine, right? So we went through residency. You're used to examining a patient, taking a history with them in person, and then making a decision about treatment. Now we're asking them to maybe get information from a primary care doctor, not even see the patient using e-consults. Or we're asking them to see a patient on a screen and work through an NP who may be doing the physical exam for you. So the biggest pushback I get is liability. Right? Like, is this somehow more risky for me to engage in this process? Like, in terms of taking care of the patient. Yes, maybe it's more convenient, but it's not the way I'm used to practicing. And that kind of goes back to at least one thing that I'm very passionate about is the fact that I don't think that we can adopt all these new forms of taking care of patients, technological or otherwise, without marrying that with some kind of coaching and mentoring and training. Like, I think the notion that you're just going to take docs and plop them in front of a video screen and they're going to know how to do telemedicine, like, I think is assuming facts, not in evidence. I mean, it's just that, we really have to figure out ways to coach them through this transition and this process.
Yeah, I think for us, whenever we implement some sort of new update or upgrade or new feature within Epic, we have these kind of meetings with the providers and physicians and everything there, and what you learn very quickly is that you've got a solution that will say this is how you should do things, but that's not how any of them do it. But they all don't do it one way either, right? They all do it their own individual way, and so what they're looking for is, yes, but I do this, so how do you make it do that without also affecting someone else who wants it their own way, right? So I think one of the challenges, we don't have standardized ways of doing things in the healthcare system and amongst providers, amongst, within a clinic, much less between clinics. So I think that's probably one of the biggest challenges, and sometimes we have the opposite challenge, and it's not so much them adopting technology is them telling us, hey, we want technology to help us, and that's not necessarily sometimes easy to find, especially when you have that variability of practice.
Well, I'm going to take a different lens here. I think when we're talking about some of these technologies that can be really helpful, the first thing that I hear is we just don't have the funds. We've already put in, $300 million on implementing our EMR, and we don't even have enough staff to optimize it the way that we need to optimize it. And it's kind of interesting because, now there's so many cool technologies in the way that we actually connect. The question's been asked of whether EMRs will become more like data repositories, and really, using different devices and different ways of actually engaging with the EMR is something of value for saving time and having, being able to tell the patient's story, engage with the patient. But we have to be able to figure out what that blend is, because it's like we're chasing our tail around, yes, we've put all this investment in, but there's these new disruptive technologies that can actually make that better for everyone, but there's not a lot of good ROIs on some of this stuff. And so there's always this pushback around, this technology investment after we've already done this, and just like anything with new technologies, there's always going to be something new that comes up. And so I think, we should challenge ourselves to really look to see what technologies are really going to make a benefit, and then maybe open the eyes and provide some education to, the leaders inside the organizations about how things have really changed just in the last 5 years. Is it changed dramatically? It's almost like, a logarithmic increase in exponential value. So it's very different than the way it used to be.
And I'm going to bring up a story that touches upon comments all of you made around telemedicine, e-consults, technology, liability. And this came out of a former employer of mine, Kaiser Permanente, where they had a video screen come in to tell a patient's family about the patient family member's prognosis. And I don't need to go into more detail, but it created kind of an uprising around technology is inappropriate, the doctor was not doing the right thing, they're dehumanizing medicine. And it touched upon all those things we just mentioned on the panel. And so lost in some of our conversations today is, what is it that our patients want, right? I know we have that traditional, again, approach to medicine. They want us to sit down with them and talk for an hour and hold their hand and examine them. And those are patients that we see in and out of hospitals now. But what about the next generation? What about their children who don't have cancer yet, don't have chronic pain, don't have these issues? Do they want the same thing out of their provider or health system? Do we see any technology where they're going to say, when I get older, I don't want to be in a hospital bed and have doctors round on me. I want to be somewhere else and maybe get medication delivered a different way by a drone, or have a consult via virtual with my physician in another country. Like, what is it do you see as disruptive technologies that are going to actually meet patient expectations but not necessarily align with what provider systems want to do? So this is a tough question. I know if someone wants to try to take a stab at what they see is coming in the pipeline that's going to be disruptive from a technology perspective because of patient demand.
Healthcare is ripe for change, and it's, probably also very difficult to make that change because of all these things, and all the infrastructure that a lot of these organizations have invested in, so that they can, maximize the ROI from all these investments, not having to just throw it away and say, oh, here's the next thing, we're going to go ahead and pick this up and go. I think there are a lot of challenges in there, but I think more and more, as you look at telehealth and e-visits and all this, the younger population probably are higher utilizers of that for routine things or patients, especially young men. I think there've been a study over at Stanford. They had a ClickWell or some sort of telehealth system, and they found that young men are probably the highest utilizers of it, right? But the different subpopulations are probably going to have different needs and different experiences, and they're going to have different resources to be able to get those. I don't know what the future is going to look like necessarily, but I think we are starting to see some changes already. Just even the way that we are transforming our practices to how we say what is a patient experience now versus what it was 1 year ago versus what it was 10 years ago. Things are changing. It's just the evolution is probably slower than some of us would like.
So it's a good question, Alan. I actually think that that's what's so difficult because patient engagement is so critical in what we're trying to do to improve outcomes. And not every single patient is necessarily going to respond the same way. There's different types of things that they want to engage with. And I think that's going to be the challenge for all of us from a technical perspective is there a way to define personas for patients and having, some sort of a list of tools that you can utilize to engage with patients, especially with Alexa and, using or My Google Home and, just different ways of utilizing technology that you use in your everyday and start to incorporate that in healthcare. I think that personal profile of your preferences is going to be important to see how we can impact care in the future.
I think of this in two different ways. One, some of the work that we're focused around is how do you help patients to choose where they want to receive their care, from the comfort of their home, right? I think we've kind of alluded to AI, but is there an approach that we can help patients to be able to, ask questions of their provider remotely, or even not their provider, some AI engine or bot before they ultimately choose where they're going to go and receive their care, and does that kind of tool help to traffic cop our patients towards either urgent care, emergency rooms, or going to see a provider for a face-to-face visit? I think it starts there. So it starts to me about how we access care for patients, because I think that it no longer will be I need to pick up the phone and make an appointment like with my doctor's provider, but how much of that can we give them and empower them to do in choosing both the place, location, timing of that visit. It's kind of ironic that you can probably schedule a haircut more easily like online than you can an appointment with your provider, right? So I think that while those aren't far into the future, I think those are going to be, sentinel to how we change like the way patients engage with their care. I think the other is how we as providers respond to their desires and start to incorporate those. A lot of my early work was around shared decision making in prostate cancer, and really focusing providers on thinking about what patients desire, right? So we often think, well, the most minimally invasive approach to something may be to give them medication. Well, but for a patient who may churn on and off their insurance, who can't afford the medications over time, maybe a better option for them is to undergo a minimally invasive surgery sooner than later. So I think that as the technologies for the types of interventions change, I think we have to think about our paradigm for how we introduce those options to patients. That's going to have to change, and using technology to kind of hone their preferences, understand their utilities, so that we can marry their desires better with the type of care that they want and when they want it, I think is how we can maybe leverage technology moving forward.
So I'm not as educated as my colleagues here on the panel, but my two comments here would be, the first one, I predict that, as the industry continues to move towards sexy tools that are coming out, right? So whatever it might be in the next 5 years, 10 years, 20 years, we're actually going to move back towards relationship-based care and more humanistic care. You can already see earlier studies where populations that lack those sort of interactions are just interacting with the world a lot differently. And I think you're already seeing spikes of depression, seeing spikes of anxiety, seeing spikes of isolation and loneliness that we just haven't seen previously. And so I do think that the industry is actually going to shift back The second thing I'll say is, while I don't know the exact technologies that I think will be present in the future, I think the technologies that we need here and now is just navigating the system better. And that's actually tied to the financial reimbursement models that are currently in play.
And you guys mentioned another great point around access to care, and we talked about earlier disparities of resources and patient populations that don't have access to these things. So I had paid a visit to the Mayo Clinic, and one of the neurosurgeons there walked me through their 3D printed circle of Willis models that they could use to show patients to say, this is where your aneurysm is. And then they're even more impressed by saying, hey, we actually have a Microsoft HoloLens. You could put this on, and you'll see the brain floating in front of you, and you can walk around it and poke at it and look at the blood vessel and magnify it. I was, wow, even cooler. And then the recent development is the access or the availability of a 5G network. So all of us now have super fast Wi-Fi. In the healthcare space, they talked about this as now they have the ability to do remote microsurgery. So the Da Vinci robot's been around for 18 years, and Stan, I'm sure you've had experience with it as a urologist, but that's where the doctor sits in this machine and the patient's a few feet away, and they maneuver multiple arms to do surgery that the human hand or human couldn't have done in a more reliable fashion. Now with 5G, you actually have the responsiveness through the internet that a physician or surgeon's hand would control a device, and that would move regardless of where they are in the world based on the speed of this network. And that's a scary thought. And I'm thinking about that, and do these tools, will they be available to the common masses, the people that have these chronic conditions, or is this gonna be a kind of pay-for-play type of mentality where we develop these models? Technology is now accessible, obviously going to be expensive in some cases, and the people who pay for it, that have access, will get the benefit of better outcomes, better safety, but what about the folks that don't get it, right? And so as we kind of come back to the theme of this conference, looking at just healthcare disparities and leveraging health IT, how can any of these technologies do you see play a role in addressing that for chronic disease for these different patient populations?
Boy, Alan's really he's raising the bar on some of these questions. So I'm going to take a stab at this a little bit. So I just actually opened up a cancer institute in the Central Valley of California, and we brought in, some of the top technology there with a brand new digital PET CT, 3 Tesla MRI, all of these really cool toys and diagnostics. And the interesting thing is that you don't actually get increased reimbursement because you've got fancier tools to use. Even though we can detect cancers smaller, it's still, there's no reimbursement for those, which is going to lead to, some pressures on the payers on, are they going to be willing to actually reimburse higher for some of these newer technologies? And then there's a piece that on the healthcare, on the provider side, that they're going to create more health inequities if they're not going to be also willing to write off some of these things. So people are not going to be able to pay for their copays or their responsibility for this because, the payer, if the payer is going to pay exactly what it's going to be no matter what technology you use, and arguing that the outcomes are going to be the same. It's your choice that you brought in newer technologies. It's going to create kind of this social responsibility discussion that needs to take place in order to tackle those inequities. The new technology doesn't necessarily mean we're going to have equal care, and in fact, in some cases, may actually create a bigger barrier.
Yeah, I think your question is a social justice question, right? I mean, it really comes down to, are we going to allow this to happen? Yeah, and I think you go to places where, I had the pleasure of working at MLK, and Tracy Donegan, our CIO, is in the audience. Like, we were able to build one of the, I think one of the most technologically advanced hospitals in the safety net. And I think that, that is a tremendous effort, but I think it was done purposefully, intentionally. And I think if we're not intentional in ensuring that these technologies actually reach the least among us, those in either geographically remote communities or those who are in isolated urban communities, then it will create a divide. So I think it's more of a social justice question. I think it's a matter of, working together to figure out where are we going to invest those resources, understanding which ones are actually going to improve outcomes, right? So not putting a Da Vinci robot at MLK because everyone else has it, but rather because it actually improves outcomes. But yeah, I think that it really comes down to political will and us as both leaders in our communities and leaders in healthcare advocating on behalf of patients to ensure that investment's made.
As a health plan executive, I'll say outcomes, outcomes, outcomes. When people come up and say, I have this technology, and I'd like to get reimbursed for it, or can it be in your network? It's just, well, tell me how it helps the patient population, and majority of them don't have an answer to that. So outcomes, outcomes, outcomes.
I think it's a policy issue here with regards. I mean, you look at Los Angeles County and the amount of homelessness and how difficult it is for people to even find shelter here. Healthcare is probably least on their mind at this point, at that stage in their lives. So I think as much as the technology can be there, even if we give them all iPhones and get 5G and everything, healthcare might not be their biggest issue. And if we don't address their other social needs, I don't think that's going to necessarily solve the problems.
Thank you for those comments.